So this cartoon is just a basic breakdown of what happens. You know, blood's got to get from your toes back up to your heart, and we do this with valves. I think y'all know that. And so when the valve doesn't close the hole, it backs up. Makes sense. Then it makes sense why it would go to the feet. So what veins are affected? Well, you've got superficial veins, you've got connector veins, you've got deep veins. It's probably a good idea to have some understanding of what veins we're typically seeing, especially if cardiothoracic is your specialty you end up going to. You're going to deal with a lot of this. So your superficial veins is where we'll start at. Your long saphenous and your short saphenous vein. If you guys do any cardiothoracic surgery, you guys will be the vein harvester, and you'll harvest the saphenous vein. That's the one they usually go for the most. But you got to make sure it's competent, make sure it's not injured, that kind of thing. So you'll do the saphenous vein cut down. So again, we've got an increase in pressure from incompetent valve. It causes flow backwards, dilates the superficial veins. Again, that's just reiterating. Now you've got something called perforating veins. These are the communicators between the deep and the superficial veins. These sometimes can be a test question, which of the following is a novel one kind of thing. So it's probably a good idea to know these perforators and know their connections from an anatomy standpoint. It's probably the best thing on that. And then of course your deep veins, your tibial, your peroneal, your popliteal. This is where you're typically going to see that. Bless you. So the deep vein insufficiency is, it's really the most of the time it's from a blood clot. Like I said before, the clot can cause damage to the valve, and that's typically where you see this. So these patients with deep vein venous insufficiency, usually you're going to see a history of DVT in their profile. So now we've got the difference between chronic and acute. Chronic, I mean, by definition, that's really what it means. Is it's an ongoing thing. So this valvular damage that we're dealing with is more of a permanent. You can't really correct it, despite all the treatment or the risks, that kind of thing. There's just things that don't change. That it just becomes a persistent. So their venous pressure in their capillary beds is always elevated. You never can get their pressures under control. So that chronic pressure leads to this permanent, persistent elevation. So now we're going to talk a little bit about how an ulcer happens. Y'all seen an ulcer before? Yes. Venous stasis. Okay. The venous stasis ulcers are actually pretty common with venous insufficiency. If you work emergency medicine, you'll see quite a bit of these. If you do hospitalist work on the floor, you're going to be managing these as well. And they're pretty difficult to manage because you have to already think with venous insufficiency, their blood flow is just not that good. So there's really just, it's hard to get these things to heal sometimes. But the pathophysiology of it, again, venous hypertension, that's the culprit of all of this. That's kind of a, if you notice, I've said that a few times, that's kind of key, you gotta have an understanding of that. And then with the increased venous pressure, you've got capillary hypertension. So the leukocytes that are in the blood get trapped. They release this proteolytic enzyme, free radicals that damage the permeability. When the capillaries become more permeable, you've got plasma proteins that leak into the tissues, and basically that's really where you have the development of an ulcer. Okay? That's kind of a more simplistic way of breaking it down. The venous pressure, leakage of fibrinogen, leukocyte microcirculation, growth factor trapping, ulceration. So someone with chronic venous insufficiency that you're going to know on a first name basis because they're going to be in your clinic all the time. this is how they're going to present. Just always going to have this as an issue. You're going to be trying different treatment modalities. They're still going to be seeing you, coming in, saying it's not working, it's not working. But the heavy legs is really, it's funny that that's kind of how the textbook describes it. That's actually what they say. My legs feel heavy. You know, and so you'll hear that complaint. Lots of cramping, dry, scaly skin. You've seen it. I've got wonderful pictures in here. We'll share those in a little bit. You'll like those. Ulcers, dilated veins. Okay, so on physical exam, what are you going to see? Well, you're going to see a lot of different things. Corona, phlebiticus, whatever that word is. That's not how you document it. You're going to document it how you see it. But this is a 4-part finding that has venous cups, blue and red telangiectasia, and stasis spots. I got a picture of it, and we'll share it with you. You're going to see edema. You'll probably see 2+, 3+ pitting edema. Does everybody know what I mean by that? Okay. So that's very common. The hyperpigmentation, fibrotic changes, the atrophy, the white spots, the leg ulcers, the telangiectasia, like I said. So here's some great pictures. All right, so there's the 4 pieces that you can see. You can see the different colorations of the telangiectasia. You've got the venous cupping, and you've got the capillary stasis. That's pretty much a common finding you see there.
What's the venous cupping?
See the bumps?
Yeah, that's the cupping.
Yeah. Is it this one you guys can see better?
Yeah.
So you've got the different telangiectasia here. Here's the red. You've got some purpling down here. You can see it down here. The venous cupping, and then you've got, see this bluish haze here? Okay, that's the stasis.
Thank you.
You see the white spots? Here's your white spots, this white blanching. And that's really how I would document that. You don't have to document it with the word. You can just say white blanching spot. And if you test for capillary refill, you're going to find they're not going to return any kind of circulation there. So really, you've got no circulation on those areas, which no circulation is bad. It's going to end up as an ulcer. And then you've got telangiectasia, which is real common as well. So what are we going to do for venous insufficiency? We've got to, now that we have an idea, we have to make sure that it's, is it venous insufficiency? Is it a DVT? Is it, you know, what is it that is actually going on here? So we've got to order some things. So first of all, we're going to do some baseline labs. I think the coag markers make sense, right? Hemoglobin A1C, they're all going to be diabetic, which in diabetes delays wound, you know, their ulcers are not going to heal. They're going to be, if you become a PA that works in a wound clinic, you're going to be doing a lot of debriding of these. You're going to be doing a lot of dealing with diabetics, and pretty much you're going to find a common denominator. Everybody's diabetic, so hemoglobin A1C makes sense. So factor V mutation, they find some strong correlation with these venous ulcers with that lab marker, so that's a genetic marker that you would order. Is it going to help you make the diagnosis? No, but it makes risk stratification change, which everything is involved around risk stratification. So, how do we make the diagnosis? Well, we order some imaging. The ultrasound really is the, that really kind of gives you the answer. There are these other options, this APG at the bottom. It actually measures, do you want to know what that is? Okay, so this APG you can order, it measures the venous congestion. It does the 4 components of venous insufficiency. It actually gives you those readouts. So that's really the most specific, and there's studies that show that's kind of the best way to make that diagnosis. But your Doppler ultrasound is going to be what you're going to order first. Okay. So what are we going to do for them? So in venous insufficiency that you're diabetic that comes in that has an ulcer, and they're saying it just won't heal. Well, there is a rare, it's not common, but it is rare. There is a malignancy that you can get that is cancerous. So you want to biopsy the ulcer to make sure. It is low, it's very uncommon, it's not something that you got to think right off the bat, oh, it's not healing because you have cancer. It's probably not healing because A, you don't have blood flow to that area, and that's kind of required. And they're probably not as compliant. And then your index, because we all know with edema, compression stockings are really kind of our first choice for that. And so we have to make sure that our index is okay. Because if they have like barely any blood flow, the compression stockings will actually, they could lose the limb. So you want to make sure your index is adequate. So you can do ACE wraps to start. That seems to be kind of, especially if you've got an ulcer and you've got to do some wound changes and dressing changes and stuff. ACE wrap is kind of your first treatment, and then you would move to these compression stockings. I'm going to assume no one has worn compression stockings before. You have? Okay. So it's a chore getting them suckers on. And for the patients that are 500 pounds and diabetic and have this stasis ulcer, it's even more of a chore. And the design of them is bad. They cut into their legs, can cause more problems there. It's difficult sometimes with these compression stockings. I think that the ACE wrap you're going to find is a better option for these type of patients, but but the compression stockings is what you're ideally looking for. Do they like to wear them? When you guys wore them, was it comfortable? No. They're not comfortable. They complain about them, and they'll wear them for maybe one day, or they might wear them home from the hospital, and then they're going to show up at your clinic for your follow-up, and they're not going to be wearing them. So very poor compliance with this. So you have to take it as a case-by-case basis. Well, what works for you? What can I do? What is going to work? Elevation of the legs. So they think that this is elevation, how she has her feet like this. They think that that's elevation of the legs. So you have to get them to understand that it's actually, you have to get the legs above the heart for it to be elevated. Well, if they've got congestive heart failure or COPD, or they have, they're severely obese, it's probably hard for them to lay completely flat and get their feet above. So again, you have to, it's about patient education. It's about, well, does this work? Doesn't it work? What can we do? How do you sleep at home? If they have chronic reflux, they have to sit, 45-degree angle up. They can't completely lay flat. And so there's all kinds of things you have to deal with to try to figure out what's the best option. So you do have options, but it's kind of limited. This is really difficult to really treat. This is why you deal with a lot of venous ulcers and that kind of stuff, poor wound healing, because you have a lot of poor compliance, and you'll find no matter how much you try to cater to the patient and how much education you give them and how much if you don't do this, it's going to get worse. It's like all they hear is blah, 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 and okay. Can't you just give me an antibiotic? That's what you'll get a lot. Just give me an antibiotic, that'll fix it. So walking, strengthening, so sending them to rehab. Do you have to set up home therapy? Can you set up outpatient visits? What's their insurance? How many visits will their insurance allow? Can they afford it? Do they have transportation? You get the issues here that we're going to be dealing with just from a logistics standpoint. Moisturizer, of course, for the dry skin, that makes sense. A weight loss plan, it's not the chicken sandwich and the smaller fry, it's actually a weight loss plan. So getting dietitians involved or getting nutrition involved, get them a nutritional consult, you'd be amazed how effective that is if they're really on board. But what they're really going to be after is, can you just write me a prescription for the phentermine? Because that's what will, the magic pill is, everything's a magic pill. So, but again, these are all the challenges I just wanted you to be aware of. Diuretics, what does diuretics do?
Yeah.
So, diuretics are great, they'll pull fluid off, but what does it make them have to do?
Feed.
It gets them have to feed. So who wants to get up at 1, and at 3, and at 5, and at 7, all through the night getting up to pee? So, what you're gonna find is, for compliance with diuretics as well, because they call this their water pill, and they don't like taking it because it makes them pee. So there is, again, lots of other options. This graded compression stocking that we had mentioned. Wound dressing needs to be moist, needs to have a barrier. You know, you can use a variety of different, I mean, it doesn't necessarily, you know, people automatically think Neosporin or something like that. There just needs to be an actual barrier. It doesn't matter what it is. You can even use a Vaseline gauze that can create a moist barrier as well. But any kind of moist barrier, because we don't want any more dirt or crap or anything in it once we've kind of cleaned and debrided it a little bit, which it seems, does that hurt them to debride the ulcer? They probably can't feel it because they just don't have a lot of feeling in their legs, so you'd be shocked at how they won't fight you as much, but they'll feel a little bit of it, but don't usually have a lot of feeling because most of it is necrotic, so it's pretty easy, it just sloughs off to debride, and then how deep you go sometimes can be shocking. I always used to probe with a Q-tip. That way I knew what I was getting myself into before I actually started debriding. If I bury the Q-tip that much, I know I'm in trouble. But anyways, so treat cellulitis. Gram-positive bacteria. What gram-positive bacteria are we looking for? What? Yep, that's right. That's typically what you see. Does MRSA grow in these? Yeah. Especially if they're healthcare, around a lot of healthcare, they're nursing home patients and stuff, you almost have to, so you have to cover them for that as well. Sometimes it's a double antibiotic. Any thoughts on what antibiotic you prescribe? So Bactrim's good. Keflex would be a good gram-positive coverage. Bank, I heard Bank, that would work. What's the problem with Bank? Yeah. And you have to, yep, peaks and troughs of Bank. That's a problem with that. So it's not a one that they use a lot. Typically the oral antibiotics will be what they'll try first, but you need to treat the cellulitis. So who are we going to send them to? We're going to send them to a lot of people. But you might be that people, depending on what you do. If you're family practice, you'll be sending off, you'll refer them to these people. If you work in a wound clinic, there are a lot of PAs that work infectious disease and wound clinic. They will snatch you up in a second. It takes a special kind of PA to do that job, but that's not for me. But doesn't mean it's not for somebody else. But you're going to do intermittent compression pump, vacuum assisted closure. Anybody seen that before?
Yes.
A wound vac? So if you've done surgery, or when you do your surgery rotation and you debride one, you'll actually probably place one there. It's pretty interesting, but it's sealed off. So once the area is debrided, there's a, you basically cut out a piece of foam to fit the ulcer. You lay that over it, and then you seal it with the Tegaderm, and then there's a lip that punctures through the Tegaderm, and then it hooks to a machine. The actual Tegaderm and all that stuff is done sterilely, and then once it's punctured through, then everything outside of it is unsterile. But then once you turn it on, you'll see it just suck down in there, and it creates that negative pressure in there, and then there's just a constant negative pressure that's pulling, any drainage, pus, anything out, it'll come out. So then there'll be a collection in the wound vac that you'll have to change periodically, and you'll have to document how much drainage you get, that kind of stuff. And then it has to be changed about every week. And then you'll notice that as it heals, the cutout you do is smaller and smaller and smaller and smaller. Those actually work pretty well, but it's getting it, getting home health set up for them to check it and getting those orders. Do y'all know, can we order wound vacs as PAs?
Why not?
Why not? Sure.
You have a license?
No, some states actually won't allow PAs to prescribe durable medical equipment, some will. So it's state dependent, if you will, but yes, we can here. Venous vascular specialist, of course, they're going to evaluate the integrity of it. Home health, we've already kind of talked about this stuff. All right, so surgical standpoint, what are we going to do? Depends on the amount of venous insufficiency we're talking about. Is it valve repair? Is it just one particular valve? The ablation is what we typically see as the treatment. Any questions about venous insufficiency? You're going to see it a lot. Pretty much in any specialty, you're going to see some varying degree of venous insufficiency. You may not even have to deal with it. Like if you're an ortho, you won't ever deal with it, but you'll see it. Varicosities. If you've seen anybody with these walking around, some of them are huge. I mean, they're like ropes. Pretty noticeable. But what's a varicose vein? Varicose veins are very tender. They hurt. Patients complain of them a lot. But it is a permanent dilation. And it's, again, the blood flow becomes so congested, the pressures become so much that the vessel walls then weaken, and you have this kind of dilation of the vessel. Primarily in the anterior thigh, calf, and ankle. That's where you typically see these. You really mostly see them in the calf and the ankle. I mean, you have some that might get up on the knee, that kind of thing. I've seen those, but typically you'll see them on the calf and the ankle most. All right, so risk stratification. Again, it dictates everything. Age, pregnancy, obesity, prolonged standing. That seems familiar from the other one, right? Kind of the same stuff. Now we're into a varicosity though, so we've got a weakening of the vessel wall. That's the difference here, okay? So that weakening really causes quite a bit of pain. And it's an incompetence, saphenoph-femoral, I should say femoral, not fenoral. Typo, cephalopopliteal, and then you remember the perforators, those are the communicators between your deep and your superficial veins. So again, it's very similar to venous insufficiency, but now we have a significant weakening of the vessel wall. So that's typically how it looks. So how patients will present, burning, itching, pain, heaviness again. Patient legs feel heavy. I don't see as much with varicosities as I do with venous insufficiency. I typically, the typical complaint I've seen with varicosities is it's just it hurts. It's very painful. I bump it up against a chair or something, or I'm walking, and it causes extreme pain. They become very tender. What are we going to see? Well, typically it's going to be a bluish discoloration, a large, tortuous looking vessel that you can see superficially. You can almost just palpate it. You can palpate a thrill sometimes in it, and so that's kind of interesting if you ever get to experience that. But there's edema, telangiectasia. Yeah, you'll see a lot of that stuff as well. There's some special testing for varicosities. It's really more about how is the overall blood flow of the leg. But a Trendelenburg test, y'all know what that is? You've heard of Trendelenburg before with other things. There's actually quite a few Trendelenburg tests for different parts of the body, but Trendelenburg for this, you're assessing to see if once you raise up the ankle or the foot, you're seeing if it turns blue pretty quick. There's not any flow. Okay. some more testing. There's the thrill I was talking about, so sometimes you can palpate a thrill when you're assessing it. I probably would know these tests just textbook wise. Are you actually going to do those in clinical practice? Probably not. I mean, mostly you're going to be able to recognize a varicosity pretty easy, palpate it. You may feel that thrill. I've actually palpated that before. So what are we going to do? Again, send them for a Doppler ultrasound. Seeing a lot of similarities here between venous insufficiency and this. But it's going to give you that. It's going to give you that diagnosis. So how do we treat this? Well, actually, there's a laser ablation treatment that works pretty well, and it handles it pretty good. You know, the anastomosis that happens when you have an incompetent vein. So essentially, all they're doing is just getting rid of that varicosity. They're just removing it, and it creates an alternative pathway, that kind of thing. But compression stockings, if they're not interested in surgery, it's the same stuff. Elevate their feet, compression stockings, exercise, weight loss, these type of things. But understand a varicosity is permanent. It's not gonna, I mean, you could try to manage the symptoms a little bit, but they're gonna continue to struggle with this. So vascular clinic, referral, wound clinic if they've got any kind of cellulitis or anything starting to develop with it as a result. Okay. Any questions?
Does it involve the valves too, or is it mostly just the walls?
It's mostly the walls, but understand it's from a damaged vessel that this started, just like venous insufficiency. So, you know, they had probably most of them, what I've seen, the common denominator is I stand a lot, or a lot of walking, or a lot of standing, that kind of thing, is what I've heard the most. So, but again, there's a lot of other things that can play into it. But good question.
How can they like coil up?
So what's happening in there is a very turbulent flow. So the blood is moving, but it's moving in a turbulent pattern. And what that tension has done is it's weakened the vessel, and it's caused it to engorge. And so when it engorges, it actually can lengthen, because pressure over time is going to make that wall incompetent. And so that's where you have the kind of torturous look of it, because it's chronic venous hypertension. So a lot of similarities from varicosities and venous insufficiency, but the treatment is a lot of the same too. And as a PA, like I said, I know you're going to have a lot of beating your head against the wall over this one, because there's poor patient compliance, and then having to get all the referrals that they need and that kind of thing. So it can be really challenging. But I can almost guarantee in almost all specialties you're going to deal with that at some point. So you're going to see a lot of it in clinic, in your clinicals. All right, phlebitis, thrombophlebitis. Anybody seen this before? Okay, so this is an infection or a injury to a vein. Okay, and typically you see this from an IV. So you'll have a patient that will, you'll go in and they'll say the nurse started my IV and it's hurting a lot, I'm having a lot of pain. And sometimes those IV catheters can get stuck on a valve. And when it's touching that valve, it's actually causing injury to that valve. And that's typically, like if it's on the hand and if the end of the catheter is in the wrist as they bend, it might kink that catheter or something. But you'll find that moving, like taking that catheter out and putting in another one, yes, they got to be stuck again, but if you're dealing with rounds and you're dealing with a patient that's inpatient, its benefit would be to change the IV out. Typically IVs that are left in too long, so IVs about every 3 days they need to have a new IV placed. So if you've got a patient that you're rounding on daily for weeks on end and they haven't changed the IV, that's a problem. So that's one of those things you have to check and make sure. All right. So in the lower extremities, saphenous vein is usually the one that's affected. It can be from a blood clot, or it can be from infection that is trapped down in the saphenous vein, that kind of thing. Medication administration, yes, potassium. When you order potassium, do y'all know the restraints on potassium? Have you gone over potassium yet?
No.
Okay, so potassium can only be administered a certain amount of milliequivalents based on the IV placement. So if you have a central line, you can infuse 40 milliequivalents of potassium versus if you have a 24 gauge in your wrist, you can't infuse that much potassium. Potassium is caustic to the vessel. It causes a lot of irritation. So you'll find patients that get, if you've got a supplemental potassium on there, they're going to complain about burning a lot. And so that the solution is to cut back the rate. Okay, so the rate's too fast. And so patients that are hypokalemic that you're trying to replenish, it can be tricky. But potassium is a real common one for causing phlebitis. Glucose, so if you've got a diabetic patient that has a blood sugar of 20 and you're administering D50, which is dextrose 50%, you actually should administer that differently. Typically when you administer a medication, you would put it into the port, clamp off the IV tubing above it, and then push the medications. With glucose, it's different because if it is a bad IV and it's not in the vessel, and you actually are putting this out into the interstitial spaces, it can necrose the tissue. So glucose is a real tough one on vessels as well. So what happens? Vessel wall damage from an IV catheter, IV drug use, and then you have some stasis, or you've got some, because the valve is damaged, so you've got blood or whatever just sitting there. And then hypercoagulability. Oral contraceptives, big one. This is a triad, these three, it's called Virchow's triad. You'll probably see that one. I would expect that one on a test. So that one, everyone should get right. But that's the triad of it, okay? But oral contraceptives always affect coagulability, so females that are on oral contraceptives, you have to start thinking about blood clots and PEs and that kind of stuff. So what are risk factors? I mean, we've kind of focused mostly on the IV catheter. That's really where you're typically going to see this. History of DVT, sure, that's a strong risk factor. That kind of thing, varicosities. But the IV catheter is the one I want you to focus most on when we're talking about phlebitis, coronal phlebitis. So there's the damage to the vessel. You can develop blood clot. And IVs actually can clot off too. So if it's just a hep lock and there's no fluid going through it, and they didn't put any kind of blood thinner through the IV, if nothing's pushed through it, they need to have it pushed and checked about every few hours just to make sure it's still patent, or you can get a blood clot. Is it probably a good idea to just push that blood clot through that catheter? Yeah, that's why when you're testing, you should actually pull back first before you push. There's a good chance, though, you're not going to kill them, though, if the blood clot does go through. But it is a risk, just so you know. All right, what are you going to feel? Well, it's going to feel very hard. So chronic IV drug abusers that come into your ER that don't know how meth showed up in their urine drug screen, don't know how heroin showed up, they don't understand that. But they've got these cord-like mass vessels, and that's just from scarring. It's just from getting stuck multiple times, it's created scars, and the vessel wall has scarred. So it'll have a cord-like palpation to it. I mean, when I say cord, I mean literally it feels like an extension cord is underneath their skin. It feels very hard. Low-grade fever is real common. It would be hot to the touch. You're probably going to have some cellulitis around it. So we'll have to treat that cellulitis, right? Tenderness to palpation, absolutely. It's going to hurt. We typically don't need to order too many tests for this unless we're dealing with like a saphenous, like I said, or something lower. But typically what you would just base it off of your physical findings and your history. you can make that assumption and you can start treating. But if you have other issues going on, the Doppler ultrasound is the right way to go for what we're going to do. Does it need to be biopsied? Certainly. There's arteritis and other things out there that can cause issues that we might need to biopsy as well. All right. Factor V gene mutation, any kind of platelet deficiencies, that kind of stuff, we certainly need to order some lab testing. So what's our treatment? Well, if we've got some associated cellulitis, typically we're going to give them some Keflex or something along those lines. Pretty easy for them to be compliant with the Keflex. And there's a broad range of dosing for that one, from 1 a day to 2 a day to 3 a day to 4 a day. But NSAIDs will help with the pain, not Norco. Okay, so if you're wondering, well, no, Norco is used. I'm allergic to Toradol. I'm allergic to ibuprofen. I'm allergic to, yeah. Now, take some Tylenol then. Let's take a break. Let's get them stretched 10 minutes. Start back at 11.